session, which is the pro and con session, which is what is required to conduct safe anesthesia with clinical skills or monitoring gadgets. So I call upon Dr. Dilnaz Devadhvala from Mumbai. She's going to moderate this session. She's the consultant anesthesiologist at Pasi General, Breach Candy and Messina Hospital. I also invite the panelists, Dr. Soma Ganesh from Chennai. He's the assistant professor at Sri Ramachandra Medical College and Research Institute. And Dr. Ankit Chauhan, who is the consultant anesthesiologist at the Apollo Hospital, Ahmedabad.
I started my residency days from 1976. And till date now, first I was as a government servant, as a lecturer in JJ Hospital, group of hospitals, where I conducted anesthesia starting right from open ether to ethyl chloride, then went on to IV relaxants, as well as IV induction agents, where propofol was never seen. And now, with all the monitoring gadgets that have come up into view, my life has become really relaxed from what the fear I was undergoing with each patient to be induced with open ether and only clinical skills, where I used to confirm that my patient was undergoing safe anesthesia. So I give over to my presenters, Dr. Soma and Dr. Anil Chauhan, for their views on this pros and cons session.
So, good morning, everyone. I'll be talking about clinical skills are required to conduct safe anesthesia than monitoring gadgets. So, before starting this talk, I would like to dedicate this clumsy speech for Peyush Malik. This talk is because of him, because he was the one who taught me, if I can do it, anyone can do it, and you can do it too. We had long chats over when he taught me how to do a transcranial Doppler through face. Going to fight him. I'm going to speak, clinical skills are much more required to conduct a safe anesthesia than monitoring gadgets. I'm not going to speak that only clinical skills are required to conduct a safe anesthesia without any monitoring gadgets. Being from a teaching institution, I cannot say that, and I won't say that monitoring gadgets are absolutely not needed, and that will be ridiculous. I'll be a fool if I speak like that. Before going to it, how do you define a clinical skill? A clinical skill is defined as any discrete and observable act within the overall process of patient care. So it's not just your procedural skill. So it includes three components: your procedural knowledge, the underlying basic science knowledge for doing that procedure, and the clinical reasoning for doing so. So your clinical skill has different components involving history taking, physical examination, clinical investigations, using diagnostic reasoning, procedural perfection, effective communication, teamwork, and professionalism. So these are all built together to form a clinical skill. It's not just doing a spinal or putting a tube inside the trachea. So I would like to ask all of you one question. How many of you believe that clinical skills are more important than monitoring gadgets in providing safe anesthesia to the patients? The whole house, including Ankit, is raising his hands. My talk is made much more easier now. If you see the overall goals of anesthesia residency programs across the world, there's only one line that will be given. The resident should be able to interpret the data derived from the clinically utilized physiological monitors. That's it. That's what is told about monitoring gadgets. And that is itself a clinical skill. It is not about monitoring gadget. And they will talk in pages and pages about how the resident should be able to demonstrate his or her clinical skills necessary for right from basics of resuscitation and life support to the independent practice of anesthesia and to the general medicine as well as critical care knowledge that he has to know before anesthetizing a patient. So we will speak some logic. Can anyone tell, of all these clinical skills like securing an IV line, jaw thrust, can any of these clinical skills can be replaced by a monitoring gadget? Never. These skills are all inherent for an anesthesiologist. These are all the basic skills that are needed for a safe anesthetic practice. So these can never be replaced by a monitoring gadget. So these are all the discussions that we had in our Facebook group. So I'd like to quote the middle one written by Dr. Vidya Mohanram from Chennai. old gadget deprived days would come as a bailout for rescue when there is equipment malfunction or a monitor malfunction or a non-availability of monitor. But a monitoring gadget can never come as a bailout at times of crisis. This is very, very important because your clinical skills are at any point of time is going to stay with you till you end your case. So they are the ones that's going to help you out in the long run. Well, let's compare the pitfalls of monitoring gadgets with the advantages of clinical skills. Your monitoring gadgets need capital investments. They have to be replaced every 5 to 10 years. There are no software updates. They are more prone for wear and tear. You cannot quantify certain parameters like pain or it's any ongoing clinical deterioration like perioperative clinical neurological deterioration that cannot be found out by monitoring gadgets. And if you have more the gadgets, it's going to be more the confusion. Less is better. And there were certain experiments by all the pharma companies that they put forward gadgets like MaxLeap, Sedasys, and Kepler robotic intubation systems. No one knows where all these systems have gone into. The Sedasys was pompously advertised as it's a replacement for anesthesiologists in procedural sedation by medical gastroenterologists, and then it was withdrawn from market in 2016. When you compare this with the clinical skills, they will never wear and tear. They may need polishing. They need an internal power. There may be a cup of coffee will brighten you up to hone your clinical skills at times of crisis. It needs just a one time of investment in learning, maybe brushing up little bit here and there. And if you have more skills with you, you are going to be more safe rather than having more amount of gadgets. Now I would like to ask you one question. How many of you stay with your patients inside operating room after induction of anesthesia? Yes, everyone says yes. So why should you stay inside? You have a technology, modern gadgets, you can connect it to Bluetooth, you can screen in your OR lounge, you can have coffee while monitoring. If something goes wrong, you can enter the theater and intervene. You are staying inside the OR because your clinical skill surpasses at any point of time during your anesthetic practice over monitoring gadgets. That is why you are staying. Your monitoring gadgets, they are just a tool. They just tell you what is happening. Before they tell you what is happening, something has happened. And it is your clinical skill that is going to catch that what has happened before even a monitoring gadget is going to catch it. That is why you are staying inside the theater, you are watching the field, you are watching what is happening in the entire OR environment so that you can give a better, safe anesthetic practice. So I'll quote some few examples. You have a 28-year-old male with an RTA shifted from ER to an OR. And you have the patient while shifting had a cardiac arrest. Will you depend upon your monitoring gadget to resuscitate? Will you put a tube, you attach ETCO2, wait for an ETCO2 rise about 20? You will not go. You will do chest compressions. It will be many people will be involved in that work. You will assess the patient clinically. You will gauge how he is improving. Of course, you will take the aid of a monitoring gadget to resuscitate him. Similarly, if you have done a unit as a first case and your alarms are not reset and the alarm gets, if there is a bradycardia alarm less than around 78, comes as an adult patient, you will not jump to give an atropine. You will always use your clinical judgment, you will use your critical thinking. So at that point of time, your clinical skill is going to help you, not your monitoring gadget. A patient shivering under spinal anesthesia, you are not, since the NABP cuff is not showing a BP, it doesn't mean that the patient is hypotensing. You will always go for an age-old technique of hands-on pulse. You see how the pulse volume is and then you will decide. And the perils of freelancing. So when I was freelancing in my initial days, I got this patient, 62-year-old farmer, who walks in a field and he comes with a Colles fracture for reduction. What will I do? I cannot go and put an arterial line, or I cannot ask for an echo in middle of night. I used to go with a two-wheeler. I won't even get money for a petrol for my two-wheeler. I have to use my clinical judgment whether the patient is having angina, syncope, or dyspnea, and if the patient is asymptomatic and his effort tolerance is good, I will put an axillary block, and then I'll do a Colles fracture reduction. The patient is safe. It doesn't mean that I am compromising the safety of the patient. So you are going to use your clinical judgment and skills to give a safe anesthetic practice instead of relying upon your monitor. So what does the literature say? There are n number of quotes. Even if you read the BJA article written by Young and Griffith, even your Cochrane review says that your pulse oximetry is not a useful indicator to prevent adverse effects. It may aid in detecting your earlier detection of any adverse events can be given, indicated by a pulse oximeter. It is not going to help you in providing a safe anesthetic practice. This is one editorial written by Stolting in Apicare Journal. He says that an improved anesthesia practice, patient safety reflects doing a number of little things using clinical skills that in aggregate will result in a big difference. And the feel of reservoir bag, we don't do this often. We put on ventilator and move on. This is one important case in neurosurgery where there was a significant brain bulge that made the clinician to take the tube out and re-intubate where there was a mucus plug obstructing the endotracheal tube. Had that anesthetist taken the bag on hand and felt for the reservoir bag, this disaster could have been prevented. He recognized it when the ETCO2 was 60 millimeter of mercury. He couldn't recognize it because he didn't use his clinical skill at that appropriate time. His hands-on pulse and outdated technique. This was posted in our group where 87% agreed that though it is not a good continuous monitoring technique, they will use it at times of crisis, and it is a very good clinical skill that will help at times of crisis. A Canadian journal in 2010 put forward this international standards for safe practice of anesthesia. The most important standards are related to anesthesia, individual anesthesia professionals. Monitoring devices play an important part in safe anesthesia as an extension of human senses and clinical skills rather than their replacement. At any point of time, your monitoring gadget can never replace your clinical skills. Your clinical skills is always going to be superior to a monitoring gadget. Our good old Wiley says the same thing. Any anesthesia textbook will say that your training has to be much more focused on your clinical skill than on your monitor. So if you're going to rely too much on your monitoring gadgets, it's going to diminish your clinical skills, it's going to compromise your safety, and if you're going to depend too much on your monitors, you will become poor in anticipating problems, compromising on your patient safety. This is a wonderful case discussed in our group by Nebu. He did an AF of 20% patient for off-pump CABG, where he used his clinical judgment. He used an NTG to maintain systolic BP of around 40, and what he says is a soft, supple heart is easy for the surgeon to manipulate, take sutures. And when the pulmonary artery bulges, then bradycardia occurs and the ETCO2 falls down, then he will ask the surgeon to place the heart in normal position. So he used the other way around. He correlates the clinical judgment with the monitoring gadget. It's another way of looking at things. So his clinical skills are so good that he picks up events even before a monitor can pick it up. So going away from monitor, even though he works in a good resource environment. He has a 7-year follow-up of cases with absolutely zero conversion to on-pump CABG, and he doesn't have a single case of post-op cognitive dysfunction or any other problems. There are n number of discussions that is in our Facebook group. I would like to quote Shiv, "Fool with a tool is still a fool. He may even be dangerous to the patient." So last couple of slides. I would like to show these 4 people. The lovely ladies, they work in a limited resource setup. They refuse to provide anesthesia because they thought that they didn't have a basic monitoring gadget, so they refused to provide anesthesia. They were all, say, pillars of advocating safe anesthesia practice. These other 2 people are all working in corporate setup with abundance of monitoring resources, monitoring gadgets, but still they use their clinical skills. I still remember Anil, who has posted a patient with partial hepatectomy where he maintained a BP of 40 millimeters of mercury, systolic BP. He used his clinical judgment of good urine output to make the patient better, safe, and he extubated. I think people will remember that case. More and more patients are going in for litigations. Monitoring gadgets will never solve this problem. Using your clinical skill to prevent or to provide a safe anesthetic practice is going to improve your safe anesthetic practice and avoid litigations. So I would like to quote Miller. Safety in anesthesia has improved a lot with advances as monitoring gadgets. Pallavi, please. I did a favor of 2 days before Friday. You were making Kiran. So you should be returning that favor. So safety in anesthesia has improved a lot with advances in monitoring and gadgets for it. But interpreting those monitoring gadgets with clinical skills is what helps us to conduct a safe anesthetic practice. This is my last slide. I would like to quote Thiruvalluvar. Vinay valiyum, tan valiyum, matran valiyum, tunai valiyum, tukkichayal. This is what is being given in our MBA textbooks as a SWOT analysis. So we have the strength of our clinical skills, And the weaknesses with us in the OR environment, the patient comorbid factors, the surgeon's abilities and human factors, and the opportunities we have inside OR to optimize patients' comorbid factors and give a dynamic patient care. And we have also threats inside the environment with unanticipated or anticipated events such as bleeding or a failure of monitoring gadgets or failure of your plans. And we have to utilize all these things with your clinical skills so that you can provide a successful, safe anesthesia to the patient. So thank you for your patient learning. Thank you for the opportunity.
Good morning to all. So after an exhaustive talk about the clinical skills, which is must for an anesthesiologist by Dr. Soma, so I would like to extend this debate on the favor of monitors, which is actually an important part of our day-to-day anesthesia practice. None of the person sitting here can imagine a patient undergoing an anesthesia without any monitoring device attached to it. So let's see. Again, this is our motto of the Anesthetic Society, to provide safe anesthesia, safe surgery, and safe, ultimately the safe patient outcome. So when you look at the flashback, where we were, imagine this scenario of 1945, a lady anesthetizing a patient with ether anesthesia. There is no monitoring gadget available, and what is happening to the patient, what is the heart rate, the rhythm, the pulse oximetry, the saturation. Nothing is to be understood by just observing the patient. But then we have come to a scenario where you have an extensive surgeries going up. This is our OT setup where we are performing a liver transplant case going on with extensive monitoring in place. You can see a small display monitor upside, not very clear, but it has all the advanced monitoring setup it had. So we couldn't assume a scenario where you are taking up a high-end case and we don't use or we don't depend ourselves on monitors. I don't have an access to pulse of this patient. How can I see the pulse? Even if it is a base tool, but we don't have the access for long hours, 12 hours, I'll take 6 hours to 12 hours the surgery is going on. So we have to rely upon the monitors, and they greatly enhance your skills and to the advantage of the patient and conduct of the anesthesia. So why is the need? Number one, the number of surgeries are increasing. Day to day we are having more and more a number of procedures. This, that surgeons are more aggressive, they are carrying out more complex procedures. The high-end surgeries which we take up to our operation theaters, which require a brainstorming before we go in for a case, then what sort of anesthesia, what sort of monitoring gadgets you require to carry on these surgeries. There are more number of geriatric patients. I think Guru was telling about 2 patients, 80, 85 years old age patient coming to his an OR for surgeries listed. So these are comorbid patients with many of the underlying conditions which we have. Then there are human errors. This is the most important thing. Clinical skills, although they are good, they cannot eliminate the possibilities of human errors. I think Veda has talked about it, Dr. Senthil has talked about it yesterday in the non-technical skill for anesthesia, that 80% of the anesthesia related events are happening because of human errors. We can't eliminate those. And ultimately you have to cover yourself from medical legal aspect when you are working in a corporate setup or in a high-end setup or taking up a patient, that clinical skills cannot safeguard you against the data which is provided by the monitor, which you document in your clinical records. So that to provide the safety against the medical legal aspect, the essential monitoring is must. And this ultimately leads to a safe anesthesia, safe surgery, and safe patient. So there is no doubt changes, the safety of anesthesia has undergone a lot of change in a positive side over the period of time. And majority of this is possible because of improved monitoring system that has reduced the anesthesia related mortality and morbidity, because the monitoring gadgets have the ability to sense the events before actually they occur. Let's say if I'm saying patient under spinal anesthesia is developing a cardiac arrest because of high spinal anesthesia. So the monitor will sense you first. If you have set your limits properly, if you are using your monitor wisely, it will give you a first indication, the beep of sound, then you can see that patient is going into arrest. Hand on pulse, yes, again it is possible, but in modern era, anesthesiologist has to look at every part of the conduct of the anesthesia. So it may not be feasible for one to just stick on the pulse. They have to do many more things. So why monitoring is important? Minimum monitoring standards have been suggested by the Society of Anesthesia Society of American Society of Anesthesiology and Association of Great Britain and Ireland Anesthesists. So pulse oximetry, non-invasive blood pressure, and ECG, electrocardiogram. These are the must for each and every patient who is undergoing anesthesia, whether it is local, regional, or a general anesthesia. This is minimum. In addition to those who are going under general anesthesia, airway gases examination, estimation, oxygen, end-tidal CO2 and vapor and airway pressure. These are must for patients who are undergoing general anesthesia. Temperature and neuromuscular monitoring are optional as of now. There are guidelines to use them, but I would recommend this two should also be included in the minimum monitoring standards. I don't know the future where it will come. So if we talk about pulse oximeter, there is a Cochrane review, data of 4 trials, more than 21,000 patients. Pulse oximetry could detect hypoxemia and related events even prior to the clinical symptoms from the patient. It does not have an evidence of improving perioperative mortality and morbidity because nobody has looked into it, because nobody has looked into it, and it is a basic monitoring. Whatever you do, local, regional, GA, you need a basic pulse oximetry. Without it, you can't do a case as of now in today's era. Temperature is the another thing. We all know the risk of surgical wound infection because of hypothermia, morbid myocardial outcomes, blood loss and transfusion requirement, which I talked about in the transplant session. We stress upon the temperature monitoring and prolonged recovery. These are the things which with the patient who has hypothermia during the perioperative period. And there is level 1 recommendation of using temperature monitoring on all the procedure under general anesthesia or regional anesthesia, those exceeding 60 minutes. And you should use active warming measure in those patients. Target temperature of OT should be elevated to 26 degree. That is what is the AHA, HCC guidelines for non-cardiac surgeries. Coming to neuromuscular, still the routine use is controversial. ASA task force has set up guidelines to use neuromuscular monitoring in all. They have recommended to use neuromuscular monitoring in all patients who are receiving general anesthesia with muscle relaxation. So to do it as an ASA task force. Residual neuromuscular blockade is the problem, where common complications are related to the residual neuromuscular blockade, and morbidity and mortality is increased with that. Australian survey has demonstrated that residual neuromuscular blockade has actually gone up over the period of years because we are not able to monitor those. We are not able to monitor the muscle relaxation effect on the patient, and it is from 21% to 31%. In 2000, Bellard et al. Showed that intraoperative neuromuscular monitoring using acceleromyography, it's a latest technology what we are using now. They have showed a reduction of residual paralysis from 62% to undetectable, very low levels. So this was a study in favor of neuromuscular monitoring. It should be used as a routine in all general anesthesia. Extra monitoring, we have invasive monitoring from the arterial pressure, central venous pressures, pulmonary artery monitoring, cardiac output monitoring. So this is a line written as old as 1872 by F.A. Mohammed, saying the information that the pulse afford is of so great importance and so often consulted, surely it must be to our advantage to appreciate fully all it tells us and draw it from every detail it is capable of imparting. So with gadgets, we can utilize this information from pulse. We can monitor arterial line, we can have pulse counter analysis, we can have stroke volume variation, we can have cardiac output monitoring. That is only possible because of a gadget which is coming to your help in your cases. Only if a hand-on pulse will not give this much of detail information from the radial pulse only. Central venous pressure measures right ventricular preload, patient's blood volume and venous tone. And a paper suggesting that in high-risk surgical patients, it is often imparted to measure CVP directly because assessment of preload is by physical examination is often unreliable. Yeah. Pulmonary artery flotation catheter, we all know severe unstable coronary artery disease, poor LV function, cardiogenic shock or sepsis. It has n number of uses, mainly with the surgery of aorta requiring cross-clamping, hepatic transplantation. We do 100% cases of liver transplant with pulmonary artery catheters. And the recent one is HIPEC, which requires a major which has a major blood and fluid shift during the surgery, and the surgery is lasting very long. Something about neurological monitoring. Invasive ICP monitoring is out of fashion now, but something new which is coming up is optic nerve sheath diameter. Serial monitoring of this diameter will help you in judging the patient condition, neurological condition, whether it is going downhill or uphill course. Then the transcranial Doppler, favorite topic of Dr. Piyush Malik. He taught us all transcranial Doppler, and it is more important in neurovascular surgeries, carotid endarterectomies, and obstetrics. It can detect microthrombi and the vascular flows during the certain part of the surgeries. Then you have any evoke potentials, spine surgeries and spine surgeries near the nerves. This can give you idea about when you're working near the nerve, what the things are going on, whether you are injuring or you're stimulating that nerve. Something about depth of anesthesia. The only validated tool till now is biospectral index. There is a lot of study for biospectral index. One largest study was BAWARE study, which showed that BIS can reduce the intraoperative awareness. And it's a big topic. Awareness has got big medical legal implications. You can be sued in the court, and you have to prove yourself that you have actually used the BIS monitoring to make your patient actually in the sufficient clinical data. So data from 25 randomized clinical trials, target zone was 40 to 60 of BIS, reduced anesthetic, it showed that reduced, 5 minutes more, reduced anesthetic use, reduction in emergence, improved patient satisfaction, and decreased incidence of awareness and call. Even ASA Advisory has suggested brain function monitoring as a part of prevention of awareness during the intraoperative period. You have blood gas monitoring, arterial and venous, that is biochemical monitoring during the surgery. Again, patients with sepsis, a lot of hemodynamic instability, you have a lot of information to gather from this, a simple test which can give you a result in 2 minutes. Then coagulation, I already talked about it, the real on-site coagulation monitoring, which gives you real-time monitoring of coagulation, quick results. It assesses whole coagulation process, analyzes within fraction of a time. It is useful in medical bleeding, and in presence of antiplatelets, you can use this. It's a typical graph of TEG. And ultrasound, lot has been talked about ultrasound by Dr. Kathirvel sir. It is useful in the perioperative period, during the cardiac surgeries, during the liver transplant, not only as a tool to measure only ejection fraction, but preload, valvular pathologies, cardiac tamponade, pulmonary embolism. This all can be recognized during the perioperative period by use of the tools, not by the clinical skills only. Yes, and they stamp your diagnosis, they stamp your clinical further management. Even the lungs ultrasound is a help of a great deal, and transcranial Doppler, as I talked about. So various studies have also supported the view that anesthesia related events are frequently attributed to the human errors. And anesthesiological vigilance and experience about the continuous display is of paramount importance. A few words of caution here, last 2 slides only. Repeat recognition of altered condition is only help. The data which you gather from your monitor will be only of help when you have a treatment available for that. And that treatment you start even earlier in your patient, then it is more effective. And to conclude, monitoring in the anesthesia has facilitated a great deal in modern anesthesia practice and helped to carry out more complex procedures with more comorbidities. Clinical skills are greatly enhanced by monitoring gadgets. Having a sound knowledge about indications and limitations about your monitoring gadgets can help a great deal in safe anesthesia practices, which leads to safe surgery and safe patient. That's lots of.
Thank you very much, Dr. Ankit and Dr. Soma. We would like you to wind up the session, ma'am, please.
What do you think about this session? Well, my boys have done pretty well in giving a debate on pros and cons session. And I feel, from my point of view, a good anesthesiologist is a one who conducts anesthesia safely using clinical skills enhanced by the monitoring gadgets in day-to-day life for a successful outcome of the patient. Thank you.
Thank you, Dr. Dilnaz, ma'am. Indeed, anesthetist is the best monitor in OT.